the day with a little video from the Paralympics Winter Committee.
Fine, stop.
I am not a morning person.
I hate early morning. Odbierz. Jadę, już jestem w drodze. Och.
Sorry. So, okay. So I hope that woke us up a little bit. So I'll begin because actually we have started rehabilitation medicine in SUSMA since 2019. So I know a lot of people are thinking that this is a little overdue, but I feel that it is only our service is only a little bit more established now for me to give a CME and to tell about the local scenario in SUSMEC. So what is rehabilitation medicine? So it's known by many names. One of it, if we go to the Northern American continent, it's physiatry and physical medicine and rehabilitation in Europe. So we are also known as physiatrists. One of the main hallmarks of rehabilitation medicine is that we treat patients who have major debilitating injuries or conditions. So basically any patients who have any diagnosis with moderate to severe disabilities. So what do? We aim to enhance and restore functional ability and quality of life. So basically most of these patients have permanent disabilities and need to return to society in one way or another. And we feel as medicine has evolved, we have understood the knowledge, the scenario, and the need of the knowledge to support these patients throughout their various stages of life. So they usually have physical impairments or disabilities affecting major organs, brain, spinal cord, nerves, bones, joints, ligaments, muscles, and tendons. So, but in general, what is rehabilitation? Usually it is synonymous with physiotherapy. So actually rehabilitation medicine is actually a discipline to make the safe life worth living. So somebody has once told me this and I feel that it summarizes rehabilitation really well. So I hope that other people after the CME, other people can also understand this a little bit. Making the safe life worth living, we are moving towards function and quality of life. And I hope that we will not get misunderstood as end of life care. So that is another part of medicine, which is palliation, palliative medicine. Our subspecialty is a lot, and in Malaysia, traditionally, it's how many it is? Seven actually: spinal cord injury rehabilitation, neuromedical rehabilitation, acquired brain injury rehabilitation, amputee and limb loss rehabilitation, and then pediatric rehabilitation, which is major, and musculoskeletal and cardiac rehabilitation. So with the arrival of COVID, a new subspecialty has been created, which is COVID rehabilitation. So many people have asked me why the need for a doctor, for a specialist even in rehabilitation, because we know that rehabilitation is supported or even conducted by many allied health professionals, which are subspecialized in advanced countries, are even PhD level holders, even here, even in Malaysia. So usually it takes a village to rehabilitate one person, especially if that person has a permanent injury and is severely disabled. We run a multidisciplinary team which we communicate with. Our two best colleagues are the occupational therapists and physiotherapists, not forgetting our rehabilitation nurse and other allied health or supportive workers like medical social workers. And also in Malaysia, this is not common, but a psychologist is really, really vital. I've also forgotten to mention the speech language therapist. So the need for a doctor or a medically trained personnel in rehabilitation is because of this. As we advance in medicine, we notice the need to start rehabilitation very early. So many studies have shown that functional outcome improves with early rehabilitation contact, and early as in acute stroke units, in ICU, in inpatient wards. So we need somebody from the medical field to understand the pathology of the illnesses at this point in time, to ensure that rehabilitation remains safe throughout the way as the patient is stabilized, and somebody who also understands the prognosis of those said illnesses. So this is really, really important when rehabilitation is started in acute care or subacute care. So when patients get more stable, as in this inverted triangle, so you see at the bottom, at the tip of the triangle, the patient has increasing complexity of need, more severe disabilities, and as they move up, they get more independent and more medically stable. So even at certain up to certain stage, after subacute stage of illnesses sometimes last for months for severe disabilities. So at this point of time, we need doctors and specialist rehabilitation as shown in this NHS model of rehabilitation before a patient can be passed to non-specialist rehabilitation, out of hospital care. The role of a rehabilitation physician and our junior doctors who are going to be trained in this field is actually to lead the multidisciplinary team, to coordinate patient care, and also to design a patient care centered program, actually patient centered program. So not every stroke is the same, not every amputee is the same, and definitely every spinal cord injury is different. So we need to understand the needs of the patient, the diagnosis, the prognosis, and really run evidence-based care. So therapy is not endless, it's not goalless. Everything, for every stage of rehabilitation, we have a set goal, and therefore we need to also reassess our goals with outcome indicators. So as we see, this is the New South Wales model of care designed in 2017 and distributed. So we see the referral starts very early, and then usually we have access and initial contact, and also rehabilitation assessment from the acute and subacute stage of patient admission. In rehabilitation, because it is basically some of patients need a lifelong follow-up or lifelong care, or even because they have permanent disability, we need to take into consideration every health aspect and also functional aspect. So if you can see this model of care, this is known as the International Classification of Functioning Disability and Health, shortly known as ICF model. If we have ICD for classification of disease, that is usually here in body function and structure. We have ICF for classification of health. So in every disabled person or majorly disabled person, rehabilitation needs to be done by stages. And at every stage, we advance from body function problems and upgrade them to plan for improved activities and ultimately in community participation. So environmental factors and personal factors are either enablers or barriers to patient successful rehabilitation. This model is not it's not like up in the clouds. It's really used in day-to-day practice. It makes our life as the rehabilitation team easier to really put into perspective what is needed at a certain point in time. So I would like to give an example for a spinal cord injured patient. For example, what are the problems in functions and body function? So everything, right, if according to the level of injury. So if you have a cervical injury and the patient is tetraplegic, you also have cardiovascular and respiratory dysfunction on top of being tetraplegic. However, with every level of preserved motor or neural function, the patient is expected to have a functional outcome, however dependent or independent he or she can be. And we are also involved in patients planning for participation in community to resume their role as whatever they are in the family, and most importantly, to return to school and return to work, also have a quality of life by enabling them to participate in sports. So like personal factors are whether, like for example, the patient is obese, older, or something like that. And environmental factors, unfortunately, are barriers. What are the policies that support their return to work and things like that. It varies in different countries. So this is like more personal to us. Rehabilitation medicine services offered in SUSMA at INUM. So since 2019, we relatively since 2019 we have started inpatient services where we offer active inpatient rehabilitation. Orthopedics has been so kind to allow us to have 6 beds in orthopedic 1 and 2 for us to initiate intensive rehabilitation. This is like so that the patient has an easier time to transition between acute care and subacute care. So most of our inpatient rehabilitation has been for stroke rehabilitation and spinal cord injury rehabilitation, just because they are the most severe. So we run a goal-oriented program, and our team is interdisciplinary, where we meet every week to discuss the upgrade in the goals or we have achieved and what we need to plan for the next week. We also involve the medical social worker and the special language therapist. Yeah, so I would like to explain a little bit about these 2 diagnoses, the spinal what we offer here for spinal cord injury rehabilitation. This is a definite need. Rehabilitation is a right, and the patient should never actually have a short admission for acute stabilization and thus discharge, unless he's just not keen to continue, just because there are too many things that need to be addressed after surgical stabilization. So as the level of injury gets higher, the more and more organ function get disrupted. Even as I mentioned just now, patient experience a lot of dysautonomia because of cardiovascular and neuro dysregulation. Patients sometimes need prolonged ventilation because of diaphragmatic and intercostal muscle paralysis. They are plagued with pain that you cannot imagine. And then they have problems of neurogenic bowel and bladder, which need to be addressed for medical needs and also for social needs. Pressure injury is our biggest enemy, and thus we in SUSMAC would like to, really have zero pressure injury for spinal cord rehabilitation patients. And of course, to move on in the next phase of life, they need to be trained. They need to go home at least being semi-dependent in ADL, and if possible, completely independent in mobility. So usually it's wheelchair mobility, or if they are incomplete injuries, they can have some form of walking. All right, so another major population that we address is stroke rehabilitation. So most patients, I don't know if this is still true, but some maybe junior doctors still think that stroke is mostly involving motor paresis, but as in a brain injury, actually stroke is a multidisfunctional diagnosis with sometimes not sparing the cognitive function. They have terrible swallowing function, and even with altered speech from dysarthria, they have mood effects. So that's more so with patients who have cortical signs of dysphasia. So in any central nervous system problem diagnosis, we have spasticity, which is like our major subspecialization in rehabilitation medicine. Patients with stroke end up with many causes of pain. We also address well, up to date measures for facilitating neuro recovery, and we do not forget conventional training to regain patient's function. And we must know that stroke is time sensitive, therefore rehabilitation must start very, very early to catch the golden period of 3 months. In SUSMA, I'm very excited to inform everyone that we have a form of therapy which is not available in many centers in Malaysia, but available here. It is the repetitive transcranial magnetic stimulation. Yeah, if you're interested, the machine is in the neuroscience clinic to be, you can join our sessions if we do have some patients. It is a modality for neuromodulation, basically to speed up neuro recovery, to encourage neuroplasticity, which is like neurosprouting, to facilitate patients' functional recovery. So yeah, it's really great that we have it here, and we hope that more and more people can be referred for this. Okay. So that's mostly our inpatient service, and our outpatient service, we do have several clinics that we run. Number one, we have our Tuesday weekly clinics for general rehab medicine. And as time goes by, we have more and more patients referred, so we can afford to run specialty clinics. So we choose to combine our spinal cord injury rehabilitation clinic with the spine ortho clinic, which is run for us. It's fortnightly fortnightly on Wednesdays, but the spine clinic runs their ortho spine runs their clinic weekly. We run a monthly pediatric, orthopedic, and rehab combined clinic so that we can have a good discussion. So these are the usual suspects from orthopedics, and that's me. And most pediatric rehabilitation is like a big core in rehabilitation medicine. 90% or 95% of our referrals are for cerebral palsy, just because that we continue care throughout this children's life and into adulthood also. The other bulk of it is spina bifida, but we have not seen that in SUSMA. A small chunk of them would possibly have, would usually be referred for muscular dystrophies, as shown in this curve. And sometimes, because we run a good collaboration with orthopedics, we have more referrals from pediatric orthopedics. And this is an example of a boy with left fibular hemimelia, limb length discrepancy. So this is like to show that he actually at 1 year, 8 months, I think, could not walk. And with the prescription, a simple prescription of an orthosis, he has finally taken his first steps. So I will just jump it up to Yeah, so that was very nice to see him taking the first steps in the clinic. Oh, sorry. And the next clinic that we run a collaboration with is a dysphagia clinic, where we have gotten good support from Kuliah of Allied Health Sciences with Dr. Rahayu, who is the speech language pathologist, who is absolutely trained in dysphagia management. Yeah, we try to get most patients to come in every Thursday to get a comprehensive assessment of dysphagia, usually clinically first, and if indicated for endoscopic assessments, and to provide swallowing treatments, whether they are from modified foods, exercises, swallowing maneuvers and such. So yeah, this is my special interest too, and I love it. I would like to announce to everyone that in starting 2022 January, we are going to run a in-house, not prosthetic manufacturing, but a prosthetic and orthotic clinic. Previously, we had to depend on HTA because of COVID regulations and all that. So now with the improvement in COVID cases, we are hopefully able to run a monthly prosthetic and orthotic clinic. And yeah, I think we welcome more referrals for amputees. So yeah, this is what's up and coming. So actually during my training, ICU rehabilitation was spoken of, but we were not formally introduced. We were definitely trained, but there were not many cases. But here I'm happy to get very good referrals when indicated for early rehabilitation in starting from ICU. So this is an example of a patient that cannot be managed by a single rehabilitation aspect only. This patient has Guillain-Barré syndrome, and he, on top of quadriparesis, had respiratory failure, cranial nerve dysfunction, neuropathic pain, and so many things that really we need a comprehensive rehabilitation care. So we started early, and fortunately with IVIG, he improved as well. And this on the right is him in the clinic about 4 weeks later, up and walking. So good outcome for this guy. Another thing that was definitely not very commonly seen, but now we are seeing more and more, is bariatric rehabilitation. So we had one patient shown here, I think weighing about 180 kilograms. I forgot the BMI, but it was super obese, morbidly obese, super obese, right? So when we have this kind of patients, we definitely cannot have usual care. It involves multidisciplinary team, excellent nursing, good durable equipment, and modified therapy. So this is an example of him, just what we needed to do to move his legs to prevent complication of immobility and promote strengthening. So yeah, if you can imagine how much that weighs. But we had good teamwork from everyone, and the patient was able to be discharged, whereby he was able to stand. He was not able to walk because the other limb had a malunion, so that needed to be addressed. Yeah. The last and not least, I would like to inform everyone that we also run a return to work service in strong collaboration with our occupational therapists and also physiotherapists. Not only that patient has problems in acutely in the hospital, we aim to discharge them functionally well, but we also need to address return to work because this is community integration. So this is an example of a dentist who had multiple fractures, bilateral radial ulnar fractures, and also a femoral closed fractures. He was a professional, but had really had difficulties returning to clinical work because of difficulty in all his hand grips, and also range of motions, and a lot of hand issues. So as you can see, this is the strength assessment. The blue signifies the left-hand side and the green signifies the right-hand side. So this is not a comparison. This is the blue is definitely the non-dominant hand. And at a stage of 3 months post-injury, then we can see the dominant hand is significantly worse than the left hand. So we really needed to intervene, assist patient and intervene and run a return to work assessment. Thankfully, this is our one of our own. So in Kuliah of Dentistry, they have mannequins, so we can do a return to work trial, train and retraining, and patient can also go in to train during his medical leave to prepare for work. Because of his femoral fracture, we had to go into the workplace to see how is the accessibility, how is his endurance and stamina, because Kuliah of Dentistry has a very, very long hallway. And also essential in every return to work aspect is return to drive. We are very fortunate and you should know how fortunate we are, because in Pahang or in the East Coast, we only have one driving simulator. This is not available in many, many rehab centers, and we are very lucky to have this apparatus and also trained personnel to handle it. So we would really, really love more referrals for return to drive. So that's about it for my talk. So I think we are early. I really welcome any questions that anybody has, anything. So Fasiha, if you're okay, I can take questions.
Yes, Doctor. Now we are open the floor for any question.
Oh, okay. Maybe there are some in the chat. Oh, there are none in the chat.
So, Doctor, how to get a referral to go to rehab?
Yeah, so maybe I would just have to explain a little bit about the team. So I am, as for now, the only rehab physician here. We have 4 MOs, medical officers, and we have our roster is online. So you could refer either to any one of the medical officers or the medical officer on call, or you could call me yourself. Yeah, as easy as that. I think if we are good, yeah. Is there any questions? Anything? I really don't mind. Because rehabilitation medicine, we are for doctors, we are not exposed. Last time when we were studying, we were really not exposed in our undergraduate syllabus. In many centers or countries, it is a subspecialty. So it is really not well known, and most people are confused of what we do. So I think if you have any questions, you can shoot your questions right now. Really no judgment. I can answer anything. So it's up to you, Fasiha, if you decide to proceed or not.
Maybe we can wait for a few minutes.
Yeah.
Maybe some of our audience still can come up with questions.
Yeah, we take questions in the chat, definitely.
Doctor, we have one question from YouTube. Okay. From Fatina Fadilah. At SUSMA, do we have group support after discharge, like to promote ADL patients, something like that?
Okay, so that is what we mean by phase rehabilitation phases, right? When we talk about group support, we usually talk about diagnosis-specific group support. So maybe the person asking can specify for what group support. So as of now, it's either macam, what do you mean by group support? So in SUSMAC, we have started a stroke group support. But outside in the community, we also have the spinal cord injury Persatuan Spinal Pantai Timur. So it is a spinal cord injury rehab association. So that is NGO and run by the survivors. If you want to talk about continuation of therapy, support. Other than stroke, we are also trying amputee support group, but otherwise we do not have enough numbers to establish diagnosis specific support groups. Other than that, it is actually integrated in the rehabilitation core itself to support patients until they are at least ADL independent in whatever capacity they have. So group supports usually are mostly more for not emotional, but usually that kind of kinship. So you have the same diagnosis, you experience the same problem, and therefore you form a diagnosis specific group support. I'm happy to say we have stroke group support. What we'd like to see group support for is actually for cerebral palsy parents to form a support group actually. But we have not enough referrals for that. Fasia, we do not have questions in the chat. So if there are no other questions, I think we are good.
Doctor, if later on, maybe some of our audience would like to ask questions, can they like email to rehab clinic or to you specifically?
Yeah, definitely. My email is anim@iium.edu.my. You can text me or call me, definitely. And also any questions we address by call. That's easier.
Okay, thank you, Doctor,
All right.
for a very knowledgeable talk for today. A lot of knowledge we can get from your talk today. So thank you again. Before we end our talk today, I would like to thank our audience for participating in this CME. We end our CME today with Suratul As and Tasbih. Again, thank you, Dr. Anim. And to the audience, don't forget to click on I attend for your attendance. And for medical practitioner, for CPD point, please fill in the Google form in the chat box. Okay, thank you all.
Thank you.